Thank you. Just to clarify, I must be a really smart fella because I went to university to study drinking. Everybody did that, right? But the difference between you and me is that I got a degree in it. My mother hates that story. So I'm going to talk about Canada, and where I'm going to go in the next few minutes is give you a little bit of context of what's going on in Canada, and we're going to talk about 3 data systems that give us some information or windows on the problem. So in Canada, impaired driving is under the criminal code. It's a criminal offense. You will go to court. You have the possibility of going to jail. With a repeat offense, you will go to jail. It's treated as a criminal offense like any other criminal offense. First introduced in the criminal code in 1925, drugs in the form of narcotics. The language specifically said narcotics. In 51, that was replaced with drive impaired by alcohol or a drug. So we've changed our standard now, so we're talking about impairment. The next big change came in 2008 when we added demand for a driver who was suspected of using drugs to submit to a standardized field sobriety test and possibly a drug evaluation and classification assessment. In 2008, the legislation was also changed to include a demand for breath, blood, urine, or oral fluid. And I don't very often give legislators credit for a lot of things, but the inclusion of oral fluid in the legislation, I think, was some forethought and some foresight into the changing of the technology that's coming around these days. I should note that the sanctions for impaired driving by alcohol or drug are the same. There's no difference in the sanctions. And also, it's a criminal offense that is comparable to impaired driving should you refuse to perform any of those things for a police officer, including a breath test. Refuse a breath test, they love that. You refuse a breath test, we don't have to go through the rest of the stuff because you're done, you're charged. So the first window we want to look at is the self-report. And these data come from the Canadian Alcohol Drug Use Monitoring Survey from 2012. The survey went on for a few years. It's been changed a little bit recently. But if we look at those people who are reporting driving after alcohol by age group, you'll notice that down there, the 15 to 17-year-olds didn't report a whole lot of driving after drinking. And those younger adults, the 20 to 24 group, is most likely to report doing so. But when it comes to driving after drug use, you'll notice there's a difference. Those young people, even though they're saying they're not driving after drinking, they're driving after cannabis. And that continues among the 18 and 19-year-olds as well. The next window we want to look at is roadside surveys. This is just a picture of how it's done. We do it off the road in a parking lot. We have people who ask people to voluntarily provide a sample of breath and oral fluid for us. We do them on Wednesday through Saturday night, so that is probably one of the big differences between what John Lacey's going to talk about and what I'm talking about here is that we do Wednesday, Thursday, Friday, and Saturday nights. The model for the survey was taken from alcohol, drinking and driving. The most common times for drinking and driving were weekend nights. The method was developed to add Wednesday and Thursday in there to see how it differed, and it's been there ever since. We work from 9 p.m. to 3 a.m. in the morning. We move constantly. We don't want people coming around to avoid us or coming around to find us, which lately has happened regularly because we're giving people $10 of free gas to provide an oral fluid sample. So we have to move quite frequently to do that. As I mentioned, we're in a parking lot. We use 2 different crews, so they're always bouncing around the city. Always a police officer on site. The police officer's role is to direct traffic. They're not making a traffic stop. They are directing traffic. I know that sounds like a subtle difference, but boy, oh boy, it sure makes a difference in terms of the legality of the situation. The vehicles are selected randomly. There's no selection going on here. It's the next available vehicle that can be directed into the lot. And it's voluntary. People are told that right up front. They're told it at least twice. It's voluntary. So in the 3 surveys that we've done alcohol and drug testing in the province of British Columbia, which is on our west coast, well known for its cannabis production, by the way, we got 86% of drivers giving us a breath sample. That's a little lower than we get in some other surveys in the past, but things are changing a little bit out there. People are less likely to do some of these things, but we get almost 80% of people giving us voluntarily a sample of oral fluid. And the first question that I always get when I talk about roadside surveys is, why on earth would anybody in their right mind give you a breath sample or an oral fluid sample with a police officer standing on the road? They've never done it before. Giving a breath test to a voluntary breath test to one of these lovely young ladies or gentlemen who's helping us out is an opportunity to find out what your alcohol level is in a relatively risk-free circumstance. And they're very good at convincing people to do this for us as well. So the most recent survey that we found in 2012, 6.5% were positive for alcohol. That's the lowest we've ever seen in the province of British Columbia. When I first started doing surveys in British Columbia way back in the 1990s, we were almost 20% positive for alcohol. Now we're down to less than 7%. But we got 7.4% positive for drugs. So we're getting more drugs than alcohol in the roadside sample. Most of those drugs, cannabis. 44% of all positive drug cases were cannabis. Cocaine is right up there as well. There's a lot of cocaine around. Opiates, amphetamines are not quite so popular. A couple of interesting little tidbits here. If we look at alcohol use by driver age, again, this is from the roadside survey. Look at that 16 to 18-year-old group. None. 0. We never found one 16 to 18-year-old who was positive for alcohol. Not one. It is illegal for new drivers to operate a vehicle with any alcohol in their system. Seems to be working. But when it comes to drugs, it's a different story altogether. 16 to 18-year-olds, they're not the most common that we find using drugs, but they're certainly using more drugs than they are alcohol. It's all across the board. If you look at it by survey night, remember I said we were out there Wednesday, Thursday, Friday, and Saturday night. The typical pattern for alcohol is that it goes up towards the weekend. In this most recent survey, British Columbia had made some changes to their alcohol laws, the drinking and driving laws. And so we found some reductions, particularly on Saturday night, but there's usually this nice increase on the weekend. When it comes to drugs, we found drugs every night of the week. There's a little uptick towards the weekend, the Saturday night there, but most obvious there is the fact that drugs are there roughly the same proportion every day. The next window that we want to look at is fatally injured drivers. Faye talked about the FARS system in the US. We have similar kind of system. It's not quite the same, where we collect the toxicology data from the coroner's offices, and we've been doing it for alcohol for many, many, many years, and drugs were added back in 2000. And we have some data that tells us that drugs are a problem. When it comes to fatally injured drivers, we're getting about 39% positive for alcohol, 34% positive for drugs. And yes, there is some overlap in there, which is about 17% of all cases. When we look at the types of drugs that are involved, these are the tested cases from the entire 11-year period. About 34% positive. Most of those cases are cannabis. There's also cannabis in some of those polydrug cases. Polydrug refers to more than one drug. We get lots of that as well. One of the interesting things that I thought was interesting anyways, when you look at the type of drug by age group. And not surprisingly, if you look at depressant type drugs, primarily benzodiazepines, you find that benzodiazepines are more likely to show up in older drivers who die. So these are fatalities again. That 64 to 75 year age group, that's the most common substance you find. Cannabis shows a completely different pattern, which is probably not surprising. It's the young people who are driving after cannabis and dying as a result. It doesn't mean that the 65 to 75-year-olds aren't using cannabis and dying on the road. They're out there too, just not very many of them. Stimulants, primarily cocaine in this case, but there are some amphetamines in there as well, tends to peak in those middle-aged years, the younger middle-aged years, primarily because people have graduated from cannabis use and they have a little more money to spend on something like cocaine. And then narcotic drugs, the opiates, again, they increase in prevalence with older drivers. If you look at alcohol and drug use among fatalities according to day of the week, again, you see this very typical pattern of increased fatality, alcohol-related fatalities on the weekends. Saturday and Sunday, Sunday generally being very late Saturday night after midnight, is when you find those people dying on the roads. When it comes to drugs, it's not quite a reversal of that pattern, but you see drugs every day of the week in almost roughly the same proportion with this little downtick towards the weekend. Very different pattern. And if you look at the types of crashes that these people are involved in, fatal crashes involving alcohol tend to involve younger males. They occur on weekends, in the early morning hours, usually after midnight. They're single vehicle, run off road, and the car either flips or hits a post or a tree or something like that. Very common pattern for alcohol-related crashes. When you look at drug-related crashes, you see something entirely different. See, all ages are involved. There's more females involved in drug-related crashes than alcohol-related crashes. They occur all times of day, all days of the week, and they're more likely to involve multiple vehicles. Now, that might be an artifact of the time of day thing. There's more cars on the road during the day than there is late at night. Very different patterns. So, conclusions. Well, drug use is very common among drivers. I don't think there's any question about that. But the pattern and characteristics of drug-positive drivers differ from those of alcohol-positive drivers. We're looking at different use patterns, we're looking at different substances, we're looking at different age groups. And the crashes differ, which is probably a reflection of the patterns of use of the different types of substances. So gaps and challenges, well, we have lots of them. I've listed a few of them here. Faye alluded to the fact that not all drivers who die are tested for drugs. They're not. Drug testing rates are lower than alcohol testing rates, which is surprising in a way because if you're testing for alcohol and you've got a blood sample anyway from a dead driver, why wouldn't you test it for drugs? The issue is money. But once you get the sample and you're going to test it, we need consistency in what's being tested for. These are being tested by different laboratories across the country. And there's a difference between what's tested for in a hospital medical toxicology lab and what's being tested for in a forensic toxicology lab. They do different things. We need some consistency in how we're doing that testing so that we can actually compare things. We need better data on crashes. We have very little data on non-fatal crashes and drivers involved. We need to know the crash risks. With alcohol, we spent years and years and years, and probably everybody's familiar with the famous Borkenstein relative risk curve where he showed that the more alcohol you drink, the greater your risk of crashing. We don't have that kind of data for drugs. We have some. Paul showed us a little bit of what's there, but we don't have that nice dose-related curve. And I don't know if we'll ever get to that dose relationship with risk, but we don't have good risk data. It's coming, but we can do better. We also don't have very good data on what concentrations of drugs are associated with different levels of impairment. Now, part of that is drug effects are considerably more variable than alcohol. We've been studying alcohol for a very long time, and we're pretty confident that we know how alcohol affects most people most of the time. That's not the case with drugs. There are a lot of issues in enforcement. One of the big things that concerns me is that the average officer on the road doesn't recognize a drug-impaired driver when they see one. And if they do, they don't know what to do with it. We need better training for our police officers. Yes, we use the DRE program. Yes, we use SFST, but we can't get to those things unless the officer who makes the initial stop can recognize the subtle signs and symptoms of drug use in that driver. And then the whole area of awareness we're going to deal with tomorrow, I believe, in a session. There's so much that people don't know about drugs and driving, and that's understandable. It's a relatively new area. We've spent the last 50 years talking about drinking and driving, and now this drug thing comes along. It's different. There are different aspects to this problem, and we need to understand how to get through to people to inform them of what's going on and the risks to themselves and to other people. And that's all I have to say about that.